Good evening, everyone. Thank you very much, Professor Ipsam, for your kind introduction.
You're welcome.
Okay, so my topic today is how to reduce falls and fractures in the elderly, which is a big issue because our population is aging and more people will be falling and fracturing at the same time. So what is the scope of the problem? Falls, well, they are very frequent. 1 in 3 community dwelling older adults will fall each year, and 2 in 5 will suffer multiple falls. So 28 to 35% of those aged 65 and above will fall each year. 50% of those aged 80 will fall each year. 5% of the falls will result in fracture and hospitalization, together with distress, pain, injury, loss of confidence, immobility, and mortality. And the reason we need to take care of falls that they don't occur, because our greatest concern is that once a person falls, he will become sort of immobile because he fears that he will fall again. And that is the worst thing that can happen because we don't want immobility. So what is a fall? It's the unintentional ending up on the ground or other lower level. It's not because of fainting, syncope, sudden illness, stroke, heart attack, act of man, in other words, in a car accident, or act of nature, earthquake, or tornado. Are they dangerous? Yes, falls are very dangerous. They are the 5th leading cause of death in those aged 65 and above. 10% of falls result in major injury, fractures, brain trauma, hospitalization. 60% of fallers decrease social and physical activity, and this is what we don't want. And 3 to 10-fold increase occurs in the risk of ending up in a nursing home, and some people hate that. They would rather die than land up in a nursing home. So what are the main risk factors of falls? It turns out that muscle weakness is very important. History of falls, so previous fall, a fall begets a fall, gait deficit, balance deficit, using assistive devices, visual defects, arthritis, impaired activities of daily living, depression, cognitive impairment, and those that are quite old. So these are the main causes related to mental health, weakness and frailty, vision defects, musculoskeletal, such as arthritis, stiffness of the joints, weak muscles, giving way of the knee in osteoarthritis, deconditioning due to immobility, neurological causes, heart problems, the environment, usually, especially at home, is not safe, other factors such as using assistive devices, and these will all lead to the effects that you see on the right-hand side, physical, be it injury, fractures, dehydration, pneumonia, even up to death, immobility, mental changes, and social disabilities. In a large meta-analysis that was done, they showed that these are the major risk factors for falls. As you see, right at the top is muscle weakness, which I'll be speaking about in a minute in more detail, what is now termed sarcopenia, so loss of muscle mass and function, just like osteopenia, loss in bone mass. And what is more of a problem nowadays is that we are seeing more and more elderly individuals having something called osteosarcopenia, so it's combined. As you see, the relative risk of falls is very high for muscle weakness, history of fall, gait deficit, fear of falling, balance problems, and arthritis is also a problem, as well as psychotropic medications, which a lot of our elderly individuals are on. Also, it turns out that the more risk factors that we have, so if we have visual problems and balance problems and environmental hazards, the more the risk factors, the greater the chance of falling. But the good news is that fixing or managing these risk factors can lower the chance of falling. The people that are at highest risk of falls are those that have fallen before, have strength, gait, and balance problems, and take certain medications, especially the psychotropic drugs, sleeping pills, etc. And why are we talking about this? Because this is all very related to our second part, which is the fractures. So it's all the calm before the major storm. This is what we don't want. We don't want fractures. Actually, in 2013, there was a fracture every 3.6 minutes in the world. By 2022, there will be 1 fracture every 2.9 minutes. So the scope of the problem, it's big. Every 2 minutes, someone breaks a bone. 1 in 5 women have a broken bone, and 3 or more bones are broken before being diagnosed. So there is a personal cost. 80% of people who have broken a hip are unable to shop, garden, or climb stairs a year after they fracture. There is also a financial cost. Who does it affect? 1 in 2 women, 1 in 5 men. People over the age of 50 who will break a bone mainly as a result of poor bone health. So 1 in 5 women who have a broken bone break 3 or more bones before being diagnosed. This is second only to cardiovascular disease, according to the WHO. Therefore, we are having an osteoporosis epidemic and a bone health crisis. Osteoporosis is usually underdiagnosed. Fractures are not recognized as sentinel events, and if they are recognized, they're undertreated. Osteoporosis, as you know, and osteopenia are not new diseases. They're very old diseases detected in mummies. What about modern day Egypt? Based on different studies, it has been calculated that 53.9% of postmenopausal women have osteopenia and 28% have osteoporosis. In men, 26% have osteopenia and 22% have osteoporosis. So osteoporosis and its major complications, hip and spine fractures, affect 1 in 3 postmenopausal women. It will become an increasing problem, especially in countries such as ours, as more and more of our elderly are going into old age. As you see, the incidence of osteoporotic fractures in women, the highest is for vertebral fractures, and it results in severe morbidity. These are the consequences of vertebral fractures: acute and chronic pain, loss of height, diminished quality of life, increased fracture risk, and increased mortality. So therefore, we have to diagnose early. A pathogenetic algorithm for the way osteoporotic fractures occurs due to inadequate peak bone mass, increased bone loss, sarcopenia, fall risk, low bone strength, and other risk factors. So the major risk factors for osteoporosis are well known to the audience: age, sex, race, BMI, rheumatoid arthritis, current smoking, glucocorticoid therapy, parental history of hip fracture, personal history of a fragility fracture, which we'll be talking about in greater details. Now, I do want to stop at the drugs that cause reduced bone mass in adults. And in particular, don't forget your glucocorticoids, as we are talking in this conference, your immunosuppressants, cyclosporin, tacrolimus, methotrexate. All these can cause osteoporosis. What is even more important, that we have new additions that you need to be aware of, particularly the PPIs that everyone is prescribing the whole day to our population. So these have been linked to, as well as the antidepressant drugs. So very important to define the fragility fracture, fracture that occurs spontaneously or with minimal trauma, such as due to a fall of one's standing height or less. These turn out to be very important because they are a precursor of further falls and fractures. So you know how important estrogen is for our bone health. And of course, as our population is aging, more and more fractures will occur. There is a continuum of bone loss. We reach our peak bone mass around about 25, 30 years. And then from there on, we all start losing bone every year. But of course, in women around the menopause, there is a sharp decline in the bone mass. And therefore, we have to pick up early bone loss and treat it. How do we do that? The clinical relevance of a fracture, using the DEXA, removing drugs that cause increased risk of fractures. So osteoporosis is not a problem if you don't have a fracture. But what links this lecture together is that, as you see, osteoporosis, fracture, falls, they're all linked, especially due to, it depends on the force of the fall as well, and the bone fragility. What is important to bear in mind, just like a fall begets a fall, a fracture begets a future fracture. For example, if you have an existing wrist fracture, your risk of getting another wrist fracture is 3.3, vertebral fracture 1.7, and hip fracture 1.9. So the age factor is important. And as I said, it's a continuum. The bone remodeling goes on forever. Of course, around about menopause, there is more bone resorption than bone formation. And this is how we land up with our bones looking. Just want to hurry up. So this is how we detect risk fracture using the FRAX score, which is a questionnaire. Also, the DEXA. What is the goal of osteoporosis therapy? Rapid reduction of fracture risk, particularly in patients. We now are speaking of imminent risk. So very high risk of fracture and long-term restoration of bone mass and strength. So the objectives are to improve bone strength and reduce fracture. Fracture protection begins with months of starting the therapy. No drug yet cures osteoporosis. questions to bear in mind: who to treat, especially in postmenopausal women, how and for how long, and how to monitor treatment therapy. Of course, the European guidance for the diagnosis and management of osteoporosis in postmenopausal women has put a position paper, and they look at the clinical risk factors, the fracture probability, and have divided it into high, intermediate, and low. High, you treat immediately. Intermediate, you assess bone mineral density, and again, if it's high, you treat, etc. Why? Because the 10-year risk of getting a fracture versus imminent fracture risk is very high. And the fracture risk increases after you get an initial fracture. This study showed that the fracture risk increased considerably after hospitalization for a vertebral fracture. So who should be treated? We have National Osteoporosis Foundation clinical guidelines for the treatment of osteoporosis, but at the end, it's individual clinician judgment on patient risk factors that is important, because you tailor the treatment to your patient in front of you. So these are the treatments that are available: bisphosphonates, denosumab, teriparatide, abaloparatide, selective estrogen receptor modulators, hormone replacement therapy, rheumatology, and cathepsin K inhibitors, odonanasatib. But I have bad news for you. It has been removed because it causes a lot of side effects. So the ultimate goal is to minimize fracture risk by achieving normal bone strength and therapy that is safe, well tolerated, easy to administer, and inexpensive. How do we get there? By understanding what regulates the bone remodeling and developing new agents that will target it. So there is a solution to the preventing falls and reducing falls and fractures in the elderly. It has been shown that if we have a fracture liaison service, in other words, where multidisciplinary intervention occurs and we screen for falls, a very simple way for screening in your clinic for falls is by simply asking the patient, have you fallen, an elderly patient above the age of 60, have you fallen in the previous 6 months or not? Doing a DEXA. And then doing community-based strength and balance classes in order to pick up and, of course, assess medically the patient, and in order to reduce the falls. So the goal is to have no falls, or at least fewer falls, and falls with serious injury. We want to keep our elderly independent. Now, there is something I have to say at this point. At least 80% of people with an osteoporotic fracture are not identified or treated. That's one side. The other thing is that not all people that fall have osteoporosis. So at least 30 to 50% of women aged 60 years and above with a fracture do not have osteoporosis. So what gives? Well, there is a couple of facts that I have to tell you. Fact number one, as we know, of course, to treat fractures and poor bone health, drugs are the first line of treatment. They're recommended as the first line of treatment to reduce fracture risk in people with osteoporosis or previous fragility fracture. The efficacy is from anything between 20 to 60% risk reduction fracture. However, there are limitations because 50% discontinue treatment after 6 months because of fear of side effects. So no pharmacological agent by itself is available also that can improve muscle-related fall risk factors. This is the problem we are facing nowadays, sarcopenia. Can you see above in the 20s? This is how your muscle mass is. In the 50s, it becomes worse. 70s, especially if you're bedridden, you lose all your muscle replaced by fat. So low strength is linked to disability. Low muscle strength increases the risk of disability and falls, as well as low muscle mass, but low muscle strength in particular. Also, in the elderly, hip fracture is a big risk, and especially if they fall sideways, or it depends where they fall. But what I'm trying to say is this. I brought this picture to show you that this man is walking the dog, and he's talking to his wife, doing a couple of things. So they should learn to do one thing at a time so as not to increase the fall.
دكتور سوزان
Yes.
قدام حضرتك دقيقتين.
Okay. Poor function predicts fracture. So if we have, they cannot do the chair stand-up test. They have poor leg power. They have a slow gait speed and poor grip strength, then, which is more or less sarcopenia. The criteria for sarcopenia is that we have low muscle strength, low muscle mass, slow gait speed. All these will cause increased risk of falls. We screen 1-minute screening tool in the clinic for sarcopenia, looking at the strength, consistency, walking, rising from a chair, climb chair, and falls. This is how we do the grip strength using a dynameter. This is the algorithm for sarcopenia. You test for muscle strength. If it's decreased, the appendicular lean mass is looked by CT scan. Physical function is tested. What should you do to prevent falls? A regular medication review. Remove drugs that cause increased falls. safe. Use vitamin D, very important. A very nice study in the New England Journal of Medicine showed that if you gave calcium and vitamin D supplementation, it reduced the risk of fractures by about 30%. Also, don't forget to do a checkup. So you check the blood pressure, especially the orthostatic hypertension should be detected. You check the feet for abnormalities, for the proper shoe wear, the heart, the brain, the vision, the ears. It turns out that people think, okay, if they walk, that's good. No, actually, fracture risk increases. Why? In this meta-analysis was done showing that walking does nothing to increase the lumbar spine bone mineral density or femoral neck bone mineral density. Why? Because osteocytes, the black spots that you see here, seem to talk to each other. They arouse each other, and walking does not arouse them. We actually need something tougher, resistance training, strength training, and doing a multi-modality exercise program that includes your drugs, because we want to make them too fit to fall or fracture. Also, you need to break up sitting time. In this very nice study that was done, it showed that more frequent breaks in sitting time, so if they got up and moved, was associated with a 45% reduced risk of having pre-sarcopenia. So this is the algorithm and approach to prevent falls and fractures, and you need to treat osteoporosis to target. I just want to show you that whatever drug you use, it all works. They all work equally well. Perhaps denosumab has an edge, especially in postmenopausal women. It has been put high up in the algorithm for treatment of postmenopausal women, and especially when this paper came out, goal-directed treatment osteoporosis. What does it say? That it may be desirable for patients with a very high baseline risk of fracture, such as those with a recent vertebral fracture or those older than 70 years. Also, denosumab has the edge of it improves muscle strength and insulin sensitivity and restores bone mass. It works also in reducing insulin resistance. So there are benefits for denosumab. It's a very powerful anti-resorptive beyond osteoporosis. And I thank you for your attention. Wow.
شكرا دكتورة سوزان، ميرسي خالص على التوك الجميلة جدا as usual. طبعا متعودين منك على كده.
ربنا يخليكي دكتورة ابتسام.